Okay, there we are.
Okay. Yes, I'll. Good afternoon, everybody. I'm Sham Chakraborty. I lead Trinnect Limited, multi-speciality telehealth care service, and we also organize specialty webinars for public information and also for what I should say, this cumulative medical CME. How do you say that CME? Under the aegis of Royal Colleges of Physicians.
Continuing medical education, CME.
Yeah, continuing medical education under the aegis of Royal Colleges of Physicians UK. And thanks to them. Today our topic is polypharmacy in older adults and nutrition and dementia. And the first part will be delivered by Dr. Sandeep Raha, FRCP, and a geriatrician and with special interest in Parkinson's disease and movement disorders. The second part will be delivered by Dr. Shabnam Daskar, who is staying in Canada and who is a trained gynecologist, but her present interest is in functional medicine. And the whole session will be moderated by a very interesting person, Anita Kumar, who is a geriatrician herself and working with cancer patients at Tata Memorial Hospital, Mumbai. So she has got a very unique experience about this geriatrics as applied for cancer patients. So the floor is open now. I invite Anita to introduce herself, and then Shabnam, and then Dr. Raha. Thank you. Anita, the floor is yours.
Thank you very much, Mr. Sham. Can you hear me?
Yeah, I can hear.
Audible?
Yeah.
Thank you very much. So I'm Dr. Anita Kumar, and I am a geriatrician by profession. I've done my MD Geriatrics and Masters in International Public Health. Currently, I'm working at Tata Memorial Hospital, and in the Geriatric Oncology Unit. We are primarily involved with geriatric assessments for cancer patients. And these are primarily patients prior to their chemotherapy. We do this assessment to know what is the potential morbidity that can happen in this patient. Also, we determine whether the chemotherapy can be given to these patients at all. What is the level of frailty amongst these patients? We also try to determine what is the mental, physical, emotional, and spiritual status of these patients. I do a lot of counseling along with my assessments, because that is one of the aspects that I look into as well. And the basic belief is that if you keep all the other aspects amongst these patients, their capacity to go through the cancer chemotherapy and the capacity to deal with this, with the side effects or deal with any issues arising due to the chemotherapy is better. And that is one of the objectives of our assessment. So that's what I do. And now I hand it over to Dr. Kar.
Hello, everybody. Good morning, good afternoon, good evening, depending on where in the world you are. I'm Dr. Shabnam Daskar. I'm a functional medicine doctor. I live in Alberta in Canada. I'm originally from India. And I am excited to talk about food and dementia today. So over to you, Dr. Raha.
Good afternoon, good morning, good afternoon, good evening. Namaste. I am a geriatrician working in NHS UK, and I have been in UK for over 40 years. I have got experience of geriatric medicine from all aspects, including pre and post-operative, as well as frailty and polypharmacy, we are only going to talk about a small portion of that as polypharmacy. The reason for my interest in polypharmacy in recent months, that I do quite a few web consultations of different patients of Parkinson's disease, which is my another hobby horse in India, and find a lot of patients are on polypharmacy. And so that generated my interest, and Sham kindly agreed that we do this webinar on polypharmacy in older adult. That's me. So I will start the presentation. Can you see my screen? You can see my screen? Okay. So I'm just trying to do it. Yeah. So the agenda is, what is polypharmacy? How does it affect? Hang on, I'm going the wrong way. Yeah. Polypharmacy in older adults, do we need to worry? Now, why we need to worry about it? Before worrying about it, like to explain what is polypharmacy, how does it affect older person, and how you actually will identify it as a medical practitioner, or you don't have to be a medical practitioner. It could be healthcare workers, could be a family member, could be a friend, and how we actually manage it. And this particular take-home message in the bottom fifth point, start, you need to remember about polypharmacy. Stop comes with 2 P's, not 1 P. I will explain it towards the end, what it means. So polypharmacy, anybody who is on more than 5 medication, anyone taking 5 or more therapeutic agent, including the over-the-counter stuff. You have to include over-the-counter medication as well, because in UK, Western world, as well as in India, more so in India, generations have grown up with many over-the-counter stuff. And we basically need to look at more on people who have got multiple morbidity, like diabetes, cardiovascular problems, cerebrovascular problems like strokes, TIAs, and history of falls, cognitive problem, COPD, and hypertension. And it's interesting that in Western world, most of the older people, as they come into secondary care, that means hospital, where I worked, have significant number of them have cognitive problem, diagnosed or undiagnosed. And there have been studies showing roundabout, if you go around in an acute hospital in UK, you will find, first you will find that 60% of the patients are over 75. And out of that cohort, you will find probably around about 70% have got some form of cognitive problem. So hospital admission itself can actually define whether you are going to have a cognitive problem or not, particularly acute hospital admission. I'm not talking about planned surgery or pre-surgery assessment admission. So what are the effects of polypharmacy in older people? It can be quite tricky because some of the pharmaceutical agents in polypharmacy are essential. And I have given some pictures here. You will agree that this woman is certainly frail. And this is how the polypharmacy should be looked at, that what matters to the patient, not to the doctor, not to the family, but what matters to the patient. Is the prescription which is being written by a doctor or healthcare professional, is it going to be effective medication? Is it going to be actually taken? In India, cost is also important, and whether they are going to have shared plan about taking medication, means family involvement or not. This is actually my uncle and aunt. Uncle died quite a few years ago, and aunt, you can see, very, very frail in India. And I had to address polypharmacy for her prescription as well. She's almost bed chair bound now. So one has to look at when they are indicated, when they're appropriate, and you have to know what drug and other drugs they are taking, and there is a drug-drug interaction. General physicians may not be aware that as we get older, our drug metabolism changes, absorption changes, elimination changes, and one of the major factors in elimination is our liver, P450 cycle, and our kidneys. So a young adult or a fit adult may have a totally different drug metabolism of absorption and elimination than a frail older person. So doctor prescribing it need to understand that as well. And the last but not the least is the compliance. What is the compliance? Interesting story about compliance in Britain, because the medicine is free, NHS is free. When we do home visit to the patient, you can find probably 3-4 shopping bag full of medicine, which has been delivered regularly by the pharmacist religiously, and GP prescribing it, thinking about they are taking it. So this is not uncommon. It may not be that common in India because you have to buy medicine, so that itself makes it a bit different. Now, effect of polypharmacy in elderly. Postural blood pressure drop, which is most commonly seen in clinics and in hospital. That means when the person stands up, their blood pressure drop, at least 20 millimeters systolic or 10 millimeter diastolic. That can make them unstable, that can cause falls, that can cause cognitive issues and confusion. Dehydration, if they are on diuretics, because most older people don't take enough fluids, so dehydration is very common. And in something like India, obviously temperature and weather is influences it as well. In Britain, interestingly, my Parkinson patient hardly ever drink any water. When you ask them to ask them how much water you drink, they look at your face blank. So I drink a lot of tea or coffee. I said, no, how much tap water you drink? Altered alertness due to drugs, Parkinsonism. I get quite a lot of referral from general practitioners for the patients who are on drugs causing Parkinsonism, and then asking whether this person got Parkinson's disease. Lack of appetite and weight loss from the drug. And as you know, when older people lose weight, they lose their muscle mass, and that can cause less strength and balance problem, causing falls. Acute chronic confusion or excitability, well known, and constipation. Constipation itself can cause confusion in older people. And this is one of the slides I picked up from US workforce. This is not older people, they're young people, active US workforce, 157 million workforce. Out of that, 38 million was in polypharmacy. That included over-the-counter medication. So effects of drugs on elderly frail. This is just a pictorial thing, what you call fall. Here there is delirium. And this particular slide is a very recent slide in my family, that my 92-year-old aunt in India, who is barely alive now, she's still alive, I'm saying barely alive, and she was on multiple medication for her hypertension, and one of them was ACE inhibitor plus diuretic plus calcium channel blocker, all three together in one medication. And this is her sodium, 110. And no wonder she was hardly conscious, because sodium of 110, if I or you get it, we won't be conscious. So those just an example I found recently. And unfortunately, because of the combination treatments available in India, It's very difficult till doctors or pharmacists or healthcare professionals tease it out that what are the agents in this combination. This is a simplified journey when we prescribe medication to older adult, and you have to think about their physiological system, which means aging and what disease process they got. You have to think about what are the consequences of that, of the physiological system, as well as your drug. And you have to think about what medication you have prescribed and what's the pill burden on that particular patient. And on the top of all that, you have to think about the behavior of the patient. Are they going to take it? And if they're taking it infrequently, like daily medicine, they're taking it 2 or 3 times a week. So is it worth taking it at all? And all this psychosocial system, have they got support? What's their cognition? What's their socioeconomic situation? So all this comes into question, and one has to think about that. How you manage polypharmacy is, I will say that I will first look at combination medication. Can they be simplified? I've given some example here. ARB, with diuretics, calcium channel blocker together, all in one combination, which I found in my aunt recently. PPI with anti-motility drug, extremely common in India to have domperidone with rabeprazole, omeprazole, eniprazoles. But anti-motility agent has got major effect, cardiac effect. And in fact, some of the anti-motility agent has been banned in many Western world recently because they can cause cardiac conduction defect. Bactericidal antibiotic, we know, is often also added on with antiprotozoal and antihelminthic medication. So you've got antibiotic with antiprotozoal and antihelminthic in one combination of somebody who had tummy upset or diarrhea. And on the top of that, you've got acetaminophen on NSAID, which is not a nice combination. Paracetamol with codeine. Codeine can cause renal impairment in frail older people on chronic basis if taken. And antilipid without the history of cardiovascular or cerebrovascular events. This is topic for another day, massive topics. And this is, I'm talking about primary prevention of antilipid agent, not secondary. And does the medication prescribed 2, 3, 5 years ago still relevant for that particular person? And do you have the basic question you need to ask? If it is a frail older person, is this medication going to outlast the life expectancy? If the person is going to be only alive for 5 years or 3 years, is it worth giving them statin? Because statin effect doesn't come into effect for 10 years or 15 years of prescription. So similarly, diuretics for heart failure, you can argue about that. Antihypertensive medication, if the person is not going to actually survive more than 2 or 3 years, are there any better or safer agents available for that older person? And I talked about compliance, because we know how the compliance happens. I wonder how many of us actually have taken a full course of antibiotic without missing a single dose, for 5 days or 7 days. I haven't. I never managed to take it. If it is 3 or 4 times a day, you always forget 1 or 2 doses. And are there any blood parameters suggesting the side effects of the drug, whether you can pick it up by doing some basic blood test? And also review the over-the-counter medication. So when the drug is indicated in older adults, various studies suggest 14 to 60% drugs are potentially inappropriate prescription. And potential prescribing omission are also common. We are talking about omission, not stopping the drug. I'll come to that in next slide. And if there is presence of multimorbidity, then you need to think about it. Like statin in advanced dementia. Is it worth trying to give that person forcefully statin if they've got advanced dementia. If they have got huge postural drop with falls in the blood pressure, is the high antihypertensive worth. And I mentioned about compliance and the combination formulation. So identification, when and how. When do we actually pick these up? In any outpatient consultation, ask them to bring all medication, not the prescription. I'm talking about actual strips and packs, because no point seeing the prescription. We see that in UK quite often. There are 20 medication in prescription, but when you actually go through it, a patient may be only taking 3 of them or 4 of them. They're not taking what is in prescription. So when the person is admitted in acute admission in hospital, could be A&E, could be ward, could be reviewed by pharmacist, or any opportunistic interaction with frail older people, which could be health club, physio, pharmacy, or when they fall, somebody has gone to attend them and check them about their falls and well-being. So one should take opportunity of any of these situations, at least flag it up. And you need to only ask 6 simple questions to the family, friend, or the patient. What medication, I'm talking about family, friend, or patient can ask this few simple question. What medication my loved one taking and why? Are there combined agents in each tablet? Are the medicine essential? Can doses be reduced or some of them can be stopped? Are there any medication interacting with other being taken? Could any of this medication cause additional symptom or condition? Does he or she needs blood test to see the side effect of the medication? So you won't be able to read this particular slide, but this is basically, I'm talking about starting the drug, because you may have people coming in who has got significant cardiovascular morbidity and they're not on anticoagulant, like if they have got atrial fibrillation, irregular heart, they're not on warfarin. So that's something you need to think of starting. If they are not on aspirin and warfarin is contraindicated, then they should be on aspirin. So all these needs to looked at. Antihypertensive, if they've got persistently high over 160 systolic and it's not contraindicated. Similarly, ACE inhibitor in chronic heart failure, ACE inhibitor after myocardial infarction, beta blocker in chronic stable angina, inhalers in COPD and asthma. These are the ones, what I'm saying, you should think about start if they are not on it. Similarly, central nervous system, gastrointestinal system, locomotor system, endocrine system. So it's not only when you see the polypharmacy, you only stopping drug, you are also may have to think about starting something which is going to benefit the patient. Obviously, you look at the patient, their longevity and their pathology and their other drugs. So look at the medication in terms of stopping medication. Long-term use of dizziness tablet, extremely common in Western world. I don't know about India. I know things like Stemetil, beta-histine, all these things, people taking it for years, not only months, years. Postural hypotension, falls, and leg swelling, they are taking diuretic just because of leg swelling, not heart failure, just swollen legs, which is not appropriate. Long-term hypnotics for insomnia. Non-specific chest pain they had 5 years ago, they are being treated for angina now by 2 or 3 different agents. Similarly, ACE inhibitor when they have got chronic kidney disease, or PPI for indigestion or curry night before. That PPI can continue for months and years. So, one need to look at all these. The recording will be available. You can look. I won't go through the whole list myself. And again, as I said, that any questions you can ask me now. The recording is available and it will be shared through our Facebook page or WhatsApp page. Thank you.
Thank you, Sandeep Da. Can you hear me?
Yeah.
Yeah, there are a lot of questions which come in my mind, and from my own experience, from my mother, who is nearly 90 years old, from my friends who are in the range of 65 to 75, in that range, and how I saw many times that how different combinations of blood pressure lowering medicines are given. And I personally, I'm some kind of a delight of doctors. I have practically every possible disease which on earth I harbor it, right from a stage 4 colon cancer to indigestion and high blood pressure to diabetes, everything, and also perhaps also COPD. I was a smoker at one time, but yeah, so I have plenty of things which I can relate to, that how I take a esomeprazole, I have a Symbicort, and then I have what is this, enalapril plus diuretics combination. I have then Jardians plus what is it called, this metformin and another combination, which is I don't remember the name, but I have all these things. So this is very interesting for me also, that how there are 7 or 8 different combinations of medicines are there. But it gives me a very interesting perspective, that is it something which you could reduce, or which as such I'm going on okay, but from my personal situation, then there is also another thing, that when people think that they're over 70 or something, in India particularly, they sort of, I'm okay with what I'm having right now, what the drugs that I'm having, this is, I'm okay. Why should I? And it shouldn't change something which is already working. This kind of mentality I've heard many times. Why should I look into something? How do I change this? And we get into trouble because we're going okay. With all these things, who knows that whether my blood pressure medicine is high or low, that it doesn't matter, because it doesn't give me a dizziness, it doesn't give me any big problem. So it's easier, much easier, rather than asking the doctor again, who may have prescribed it 10 years back. You have this prescription, go to the pharmacy, get the medicine, come back and try to take it diligently.
So, I mean, I would to have another caveat to that. In my Parkinson clinic, I have patients who take antipsychotic, and they have been given antipsychotic for schizophrenia or bipolar depression by psychiatrists 20, 30 years ago. And they were in their 30s and 40s at that time. Now they're in 60s and 70s, and they are developing extrapyramidal Parkinson's side effects of those medications. So patient asked me why I'm getting this now. I've been taking it for 20 years or 30 years. Why didn't I get it then? I said, because your brain is 30, 40 years older. As the brain gets 40 years, 30 years older, the effect on the brain is different than it was 30 years younger for the same medication and same dose, so which is well proven in research. So as you say, 10 years antihypertensive, 10 years ago may have been okay, but your vessels, your heart, your brain, everything is 10 years older. So we don't actually know. It's always better to have a look at it very critically and objectively.
I will ask my doctors to have a relook, because I started my blood pressure medicines in 2002, if I remember right. So it's 20 years already. So I'll ask them. Thank you very much. I appreciate it very much.
A question from
Dr. Raha, I
Jayanandan.
have a question. I think we'll wait for Jayanandan. If you have any question, please go ahead. After that, I have some questions for Dr. Raha.
Okay.
And some comments as well.
All right. Janandan, got any questions? You can unmute yourself. You are muted.
Okay.
Okay.
So my question and comment is, so Dr. Raha, just as you have found in your patients in India that they are on multiple medications, do you suggest, because a lot of this thing has to be done by the person who's taking care of them. So if it's children, they're, they take care of all this.
Yeah.
One of the things I find, and again, like you, I found many of them on multiple medications. Many a time they don't know what they are taking a particular medication for.
Yeah.
So would you suggest that when the person goes to the doctor, they should ask, doctor, why am I taking this? Like, I've seen patients on beta blockers for no obvious reasons. Some have been on anti-anxiety medications because sometime 20 years ago they had some acute anxiety.
Yeah.
Do you think that is a good practice, that they should ask,
it is.
why am I on this?
I completely agree. And particularly the problem in India will be that, as you know, that the consultation timing is so short and is detailed discussion is not possible. But on the other hand, the positive side is that the most patients are paying the doctor to see them. So if you are paying money, if you're buying something from supermarket or shop, which is very similar, you check, isn't it, that it's in right order or not. But that's one thing. And the second thing is, personally, I think that most people in India still go with the trade name of the drug rather than pharmacological name. And the trade name doesn't give you anything. In fact, most pharmaceuticals try to hide the different combination of pharmaceutical in their product by changing the trade name in such a way that you can't really, make out. Because I have got this practical experience. I Googled them, and when you Google them, even from Indian site, it says this is for hypertension.
Yeah.
But there is ACE inhibitor, calcium channel blocker, and diuretics in it. But it will say it is for hypertension. It won't give you the individual product, different pharmaceutical. It will just say it is used for hypertension. So you have to really dig it hard to find it out, and most medications should have that writing. That's by law anyway.
So
on the packet.
to circumvent that problem, what I ask my patients to do, because most of my patients are in India, I ask them, like, I send a sample of how I want the image, because many a time I have found that if it's a strip, they take out the pill. So the the drug information is gone. So I get a picture with nothing on it, or it's a poor quality image.
Yeah.
So I make my patients do quite a lot of homework. So I ask them, just send me the, again, like you said, commercial names, I won't know. So I have Googled and found out many a time. And sometimes the information is on the strip is different from what shows up in
on the box.
Yes. And another comment I had to make, you talked about over-the-counter products in the UK and even in North America. In India, another thing I insist upon is a whole bunch of Ayurvedic stuff that people take. Many of them are extremely toxic, and they have no idea that these are toxic. They think, oh, this is natural. So in my practice, I make it a point. If you are on Ayurvedic stuff, either you have to stop them, or if you want to continue having them, then once you are done with those, then I can take care of you, because some of them are really extremely toxic. That is one thing. Another thing I wanted to mention, Dr. Raha, is you talked about drug-drug interaction. So there are a lot of drug-herb interaction as well. And there are a lot of online tools available for people to check that. So number one is they need to, of course, review what they are on and why they are on. So thank you very much, Dr. Raha. That was very good.
I have a small comment. I have a small comment on that. That very recently, I think in the last 3 days, one Calcutta doctor, he really prescribed that all these 3 doctrines of treatment, like homeopathy, Ayurveda, and allopathy.
Shyam, we can't hear you.
Shyam, you got cut off. You got cut off.
I think, Dr. Raha, we will continue.
Yeah, I think so. I think we have got another, someone else has joined as well, I think.
Oh, hi, Sukanya.
Shukanya, yeah. And
Thanks for joining.
so we are in the second half of the webinar now. Dr. Shabnam Daskar is going to talk about, brain and food. So
Food and nutrition.
Yeah, I'm keen to hear about this because my brain is coming up to almost 70 years old. So I need to know all this.
Thank you, Dr. Raha. Dr. Raha, you need to stop sharing your screen, then I can start sharing.
Yeah.
Okay, so what I will talk about today is food and dementia. So just I'm providing a little bit of an outline. So I will talk about the use of food in the prevention of dementia and not about treatment, because in the interest of time, I won't have time to talk about treatment. We have a few studies coming up now, very small studies, where they have used food for the treatment of mild cognitive impairment. So when we say dementia, as a functional medicine doctor, we look at all of dementia, or maybe we can even say, neurodegenerative conditions as one umbrella. Whereas, dementia, as all of you know, Alzheimer's disease is the commonest dementia, but there are other types of dementia as well. Dr. Raha takes care of a lot of people with Parkinson's. There is Parkinson's dementia. Then there is frontotemporal and Lewy body. So a whole lot of different types of dementia are there. And many a time, Alzheimer's is actually not just one disease. It is a combination of many. Dr. Raha can tell us about that. So when I say cognitive decline, I mean everything together. As a functional medicine doctor, we look at all together, because instead of, in medicine, we are very used to specializations. Neurologist, I was an OBGY before, but the body didn't get the memo. The body works in, as a network of networks. So I talk about cognitive decline, and it can start with something as simple as brain fog. You feel that your thoughts are going through, patients here will describe them, I feel my thoughts are going through jello, I lack clarity. Is that a sign of dementia? Now, sometimes it is not. Sometimes it can be something as simple as not sleeping enough. But then it can start very subtly. That is number one. And Dr. Raha, you pointed this out as well. A lot of patients, even with dementia, are not diagnosed. And some who may actually show symptoms which suggest dementia may actually be something acute. Like you mentioned, acute infection, electrolyte imbalance in older people. Those are some of the common ones. So going back to my primary topic of food, I am going to start sharing my screen. And sorry, 1 minute. Okay. So in functional medicine, this is how we look at a patient. It's not just only food. As you can see in this, food is just one component of everything else that is going on. And long COVID, so COVID infection is again something that we have to be very aware of now, because a lot of studies are coming up now which suggest that COVID may be a risk factor for long-term cognitive decline as well. And many patients have experienced long COVID, where brain fog, anxiety, mood disorders, profound fatigue, these have been extremely common features. Now, long COVID has more than 200 different symptoms, but that is something we have to be aware of. So COVID can also increase risk for heart disease as well as dementia. Now, out of all these things, of course, I'm only going to talk about food today. So when it comes to brain health, I try to simplify it to a point where it becomes, sometimes it can get very overwhelming looking at that whole network of networks. But as an individual, what are the three main foundations you need to look at? And number one is optimal blood glucose levels or blood sugar levels. Number two is optimal blood pressure levels. And the third is low levels of chronic inflammation. Now, we know that having diabetes, or more importantly, poorly controlled diabetes, increases your risk for dementia and all the other problems, heart disease as well, mood disorders also. But recent studies have shown that even if you do not have diabetes, so what is diabetes? And I'm talking about type 2. So diabetes is when your blood glucose levels have reached a certain threshold. Beyond that, your doctor says you have diabetes now, you need to be on medications or dietary changes and things like that. But recent studies have shown that even if you have not received a diagnosis of diabetes, but your blood glucose levels are higher than optimal in younger age group. So in your 30s and 40s, if it is less than, if it is more than, so in Canadian terms, it is more than 4.9 millimoles, and in Indian terms, that would probably be around 90, 95. So the units are different. Yeah, it's different in different parts of the world. So even a fasting blood glucose of that level, if it persists over a time, number one is your risk for diabetes goes up, of course. But what they found is even if you do not develop diabetes later on, your risk for cognitive decline, dementia, Alzheimer's, everything goes up. And in fact, Alzheimer's is considered to be type 3 diabetes. So it's diabetes of the brain. That's a different type. It's not, again, as you know, we don't really know exactly everything about Alzheimer's. There are multiple reasons, and we don't have a specific treatment today. The next is looking at optimal blood pressure levels. So optimal blood glucose, optimal blood pressure, these are two things that you need to have a conversation with your doctor, because what is an optimal blood pressure for someone who is in their 20s or 30s? And in India, young hypertension is extremely common. So that is something, and often undiagnosed because people don't go around checking their blood pressure. So that is something very important to keep in mind, because what is a normal blood pressure for someone who is in their young age or middle age versus, as Dr. Raha mentioned, someone who's 80 or 90 years old. Do they need to have a lower blood pressure? Definitely not. But in this thinking, sometimes people forget, including doctors, that someone who's 40 years old cannot go around, living their daily life with a blood pressure of 140 by 90. I've had patients in India telling me, my doctor says it is okay, I don't need to take a medication. I said, no, I disagree. You are only 40 years old. You have to prepare for the next 40, 50 years of your life, because lifespan has gone up everywhere in the world, including India. The third important factor is low levels of chronic inflammation. So chronic inflammation is basically, acute inflammation is when let us say you get a cut or you get a bacterial infection, your immune system starts taking action, your cut is healed, everything is fine. You have a urinary infection, it is treated and you get better. But chronic inflammation is sort of like a, small, slow, smoldering fire, like charcoal burning in the background, so to say, which continues in your body long term. And chronic inflammation is related to 95% of chronic disease, whether you talk about cognitive decline, heart disease, diabetes, mood disorders, bowel disorders, IBS, anything you name, that is related to chronic inflammation. But the thing is, how will you know whether you have chronic inflammation? Now, there are some blood tests. There is no one marker for chronic inflammation. If an acute inflammatory marker like a CRP or a ferritin stays high for a long time, then we have to look at. So I'm not going into chronic inflammation now, apart from mentioning that food is one of the biggest sources of inflammation. And I know we have a recording of this video, so there will be doctors listening to it later on. In my world, we say that atherosclerosis, so that is basically the underlying problem in heart disease and stroke as well, is a postprandial phenomena. That means it is something that happens after food. So the food you eat, it triggers a sort of an inflammatory response. Now, some amount of inflammation your body has the ability to deal with. But if it is excessive, then it overwhelms the body's ability to respond to that inflammation, and that can cause long-term chronic inflammation. So now, why are we talking about brain and food? So our brains are just about 2% of the body weight, but brains use up 20% of the entire energy requirement of your body. So a 2% organ using up 20% of energy, obviously that energy is extremely important for the brain. And the other big energy hog is your immune system. And because of the ongoing pandemic, all of us are very interested in maintaining our immune resilience. So that is, one more very important reason where you need to look at your food is for immune system, and every disease is an immune system problem. So no apologies for this complex looking diagram. What this shows is, so this is what is happening in your mitochondria. And, over the years, Dr. Raha will also agree with that. We are looking at a lot of diseases like Parkinson's, like dementias, and a lot of, only thing is we don't have a specific marker yet. Is it a problem of mitochondrial energy? So mitochondria are the energy making cells in your body. So each cell has a mitochondria, and this is a picture of a mitochondria and how complex it is. So mitochondria produce energy called ATP. Now for the mitochondria to produce energy, it needs a whole bunch of nutrients. In this slide, you can see there are whole, and I'm going to just simplify it so that it's easier. Now on this side, you can see I've made a list of all the different nutrients, and I'm going to just, to avoid distraction, I'm going to cover that. So basically you can see there is B vitamins, folate, vitamin C, E, CoQ10, iron, magnesium. And one more thing I wanted to mention, Dr. Raha, you talked about prescription medications. Many prescription medications also deplete nutrients. For example, statins deplete B vitamins and coenzyme Q10 as well. Then there are some medications which deplete magnesium, and magnesium is involved with about 300 to 400 different enzymatic reactions in the body, and a blood magnesium. So a serum magnesium test will never tell you. So in this list, you can see that there are a whole lot of nutrients. And this is the reason, quite often you will find this, and it's always, someone or the other posting on WhatsApp or on other social media, vitamins don't help you. Now, the thing is, the problems very often is many of the studies have been done using a single nutrient. Now, if a person is deficient in iron, it does not mean that that person is not deficient in any of the others. So if you correct only iron, you can see that that still leaves a whole bunch of other nutrients. So what is going to happen with them? Our bodies work as a network of networks, so not like just a single nutrient doing everything. So that is one of the things. So I talked about the energy requirement by the brain, and of course a lot of the energy has to come from food. But interestingly, our bodies also have the ability to generate some energy. So that is the reason. Now food broadly is divided into proteins, carbohydrates, and fats. Now, in the proteins, there are some which are considered to be essential. Proteins are made of amino acids. So there are some amino acids which are called essential amino acids. That means our bodies do not have the ability to make them. The next is fat. Now, there are some fats like omega-3 fatty acids, for example. That is an essential fatty acid, which means your body does not have the ability to make them. So they either have to come from food or a combination of food and supplementation. Third is carbohydrates. Now, there are no essential carbohydrates. Our bodies have the ability to make carbohydrates from other things. This is, if there is just one message you want to go away with from here, that is something you need to remember. So carbohydrates, our bodies have the ability to make. Some amino acids are essential. Some fats are essential. So if you're deficient in those, obviously, So one of the things with Alzheimer's disease, a lot of recent research is coming up. It is considered to be what is called brain glucose hypometabolism. Now, sorry about the long, big terms. What it basically means is the brain starts losing its ability to use glucose as a fuel. So if it can't use glucose as a fuel, what are the other options? But the brain still retains its ability to use ketones. Now, I'm going down many different rabbit holes, and I don't want to go down that path today because we won't have time. So I am now switching gears to the two studies that I wanted to talk about. But more importantly, I want to keep time at the end and provide you, with with strategies that you can implement right away. So the first trial that I wanted to talk about is called the MIND trial. And as you can see from the very long name, Mediterranean Dietary Approaches to Stop Hypertension Intervention for Neurodegenerative Delay. Now, Mediterranean diet is, there are lots of studies supporting the use of a Mediterranean diet for benefits in brain, heart, diabetes, everything you name. The next is the DASH diet, so dietary approaches to stop hypertension. Now, the original DASH diet was done in the 90s, probably 97. And in the first few studies, they did not include people with diabetes. And in the first study, actually, they had food delivered to the participants. Now, if you're, I hate cooking. So if someone is going to deliver food to me, I'd definitely eat that. So obviously, compliance was very good, and they found that their hypertension was managed better. So they decided to combine the Mediterranean diet and the DASH diet and make it what is called the MIND diet for to look at people and see how it goes. But here, what before I talk about what is included in the MIND diet, one thing I wanted to say is when it comes to clinical studies. So when we talk about this study showed this and this study showed that, as many of you know, and many of you are physicians, so you're aware of this, there are different types of studies. One is what is called an epidemiological study. So a MIND diet is, for example, you ask a group of people, and usually in these epidemiological studies, the group size is very big. So which is very good, because what these studies do for us is they give us an idea of, what is a hypothesis I can come up with. So the MIND diet, what it did is it asked a group of people about the food they were eating. Now, in the world of food and nutrition and this is called a food frequency questionnaire. So a food frequency questionnaire is validated, but the point is, how many of you remember what you ate 2 days ago? So there are accuracy problems, and these people were asked just 2 times over a period of many years. And this was like 177 different, things included in the questionnaire, which asked them about, did you eat this? How many times in a week did you eat that? So yes, there are other more advanced techniques available now, like metabolomics and all that, but these are not that easily available. So a food frequency questionnaire is not the best data, but it is something that we can, look at. So when we look at, a study like the MIND study trial, what it did basically is ask people, what are the things you eat? Versus the other type of study is what we call an interventional trial. So interventional trial is one group of people get a certain intervention, and here it can be food, it can be, I'll come to that, another study, which is the finger trial, and another group of people don't get it. So if you see that the group of people who got the intervention, they are showing better results, then you can say that, okay, the intervention made a difference. Whereas in these kind of studies like the MIND trial, the epidemiological studies, sometimes it is difficult to know whether these people who eat better food, do they also exercise more? Do they sleep better? So this is the healthy user bias that we say. And as you know, Alzheimer's is not, or any cognitive decline is not just one problem of food. It's a problem of a lot of things together. So these are the 2 types of studies. So when you see that, if eating blah, blah, blah is going to give you better brain function, the important question to ask is, what is the study exactly looking at? And so this is important to keep in mind. And another thing I wanted to highlight is, again, this will be evident from this trial as well. So what did they eat in the MIND diet? So this participants were asked a bunch of questions, and they came up with a MIND diet score. So in that score, these were considered to be the healthy food, and these were considered to be unhealthy food. Now, in the list of healthy food, why have I highlighted whole grains? I will show that in a minute. And Dr. Raha, how am I doing for time? Otherwise, I'll rush. The next thing is, in this list, I highlighted cheese.
You're doing okay. got another 10 minutes at the most.
Okay.
Okay.
So I will rush through this a little bit. Basically, what I wanted to highlight is what it did not include in this. The MIND diet does not include processed food. It does not include sugar. And though wine is there, it was mild to moderate amounts of alcohol, not high alcohol. As we know, alcohol is not your brain's friend. So most importantly, sometimes we look at what did the people eat. However, it's also important to remember what they did not eat. So what is missing in the food is all these different things. So when it comes to whole grains, so this is the continuous blood glucose monitor data of one of my patients. And again, as you can see, I do quite a deep dive into different parts of your, different lifestyle changes. Here you can see, I'm just going to show the thing about whole grains. So he had a lunch of multigrain flour chapati with bhindi, dal, raita, and half a bowl of sevia. So sevia is those vermicelli. Now, I know many of you think this is a very healthy food. Like, what is wrong with this? So you can see here. Now, this is in the Canadian unit. So 10 is 180 milligram per deciliter in the Indian equivalent. This is definitely 10 is not my suggested upper limit. Mine is about 140. So here he ate the food. Then he went for a walk. And when he went for a walk, his blood glucose levels came down. But what I'm trying to highlight here is after this, multigrain chapati, now you can say it could even have been the sevia, it could have been the bhindi or the dal or something. So what I usually ask people is, what do you think what do you think raised your blood glucose so much? Sometimes they know because they have checked eating something else with similar food, but they didn't have, let us say, they didn't eat roti that day, they ate rice and the blood glucose levels were lower. So it's like a medical detective to find out which are the ones that raise your blood glucose levels the highest. So this particular meal raised it to, you can see it went up beyond 180 actually, so beyond 10. And then of course, eventually it did come down. So my point is, when you say whole grains are healthy, they are not healthy for all. Now, this is not the typical response for everybody, but for my patients in India, because diabetes is so common. And this patient was not diagnosed as diabetes by his doctor. I said, I would disagree. But the point is, when you ask, let us say you ask me, I have blah, 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 blah condition. Should I take this? It's very difficult for me to answer because I look at much more granular information, and Shyam knows that, and Shyam can sometimes find that extremely frustrating because I ask him, I don't know this. You have to give me this information and that information. So obviously the next point is, if you are eating a certain kind of food long-term, so that is what they found, long-term compliance makes a difference. The reason I don't use the term diet is whenever we use the term diet, people have this impression of this is short-term. Your health is not decided by what you do over 1 or 2 days or 2 weeks or even 3 months. It is what you do long-term. It is what you do over a long period of time. So I never talk about diets. It's a whole life plan, and it is lifestyle change which is sustainable for you over a period of time, and different things for different people. So yes, just, okay, I'm just going to switch to something healthy for 2 weeks, or I don't know what it is. But after that, I'm not going to bother with it. That you're not going to see the same kind of changes. One more thing that I see all the time in my patients is the changes you see in your brain health, mood issues, everything, blood glucose levels will be decided by, number one, what was your baseline diet? If you ate a lot of carbohydrates, a lot of oats and muesli, and I don't know what else, and from that you switch to prioritizing protein, eating more healthy proteins like fish, or for vegetarian people, it becomes a bit of a challenge, maybe things like paneer, you can see a dramatic difference in a short span of time. But if you are already eating fairly healthy, then you may not see some major change right away, but still you can experience a lot of changes over the long term. So there are many different nuances to this. The next study is, this is from Shyam's country. So Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. This was done, the first study was done in 2015. So this is the finger trial, finger study. And all of us were very excited about this study because we know that, the frustrating experience with finding a curative treatment for Alzheimer's, billions of dollars have been spent. Nothing has come up yet. Hopefully something will come up. But the fact that whenever something is given more importance, obviously there's a lot of research dollars that go into that. So we are all over the world, we are excited to see studies like the finger trial, because finally they have decided to look at multi-domain. So what is multi-domain? They looked at diet, exercise, cognitive training, and vascular risk monitoring. So vascular risk monitoring basically was looking at the patients to make sure that their blood pressure was under control, their diabetes was under control. And this was a very intensive trial. So the first finger trial was done in Finland. Then all over the world, there are a lot of finger studies coming up now. In fact, Singapore has done one called Singer. Korea has done one. In India, they're planning one. The challenge is this is not a very simple trial to do. So the number of, in fact, I have a podcast called the Brain Podcast. So me and my co-host, we did quite a deeper dive in the finger trial. So what they found is when they looked at a multi-domain intervention of food, exercise, cognitive training, vascular risk monitoring, one very interesting thing is compliance was very high. So a lot of people sometimes can just, decide not to take part in it. But as you can see, the age group was between 60 and 77. Now we know that Alzheimer's starts 20 to 30 years before you actually develop symptoms. So if you start late in life making all these changes, does it mean it will not make a difference? No, it will make a difference. But you need to start focusing on your brain actually throughout your life. So it's not like, oh, when I'm 60, I'm going to decide to focus on my brain and prevent dementia. For some of you, it may be too late. I'm sorry. So anyway, going back to the finger trial, they have this inclusion criteria where Shyam, actually, this is apparently an app. Now, my Canada App Store did not have the CADE app in it. So cardiovascular, as we know, heart disease and brain disease are not different. They are related to each other. So they found a risk score of at least 6 points, and cognition at the level are slightly lower than expected for that age. And as I said, this was the very intense intervention. Now, the other thing is when you look at 60 to 77-year-old people, many of them were retired. So the other thing is they were able to go in for those appointments as well, because many of these appointments were in person. Versus if it is younger people who are working, who have, families to manage, that may not be that easy. So we have to look at different ways of delivering. So what was the food on finger? So this is the healthy Nordic diet, a lot of fish, a lot of fruits and vegetables, and a lot of healthy oils. That is, and Shyam can probably tell us more about the Finnish diet, and we'll know. So what was the result? Again, the result was cognition improved. More interestingly, ApoE4 gene is supposed to be one where you have two copies of it. So either you get one from your mother and one from your father. So people who have either one or two copies of the ApoE4 gene are at a much higher risk for Alzheimer's. What they found here is even people with the ApoE4 gene carriers, even they had cognitive benefits from the intervention, which was extremely encouraging. So basically this trial, and we are waiting for a lot more trials to come up. So there is worldwide fingers now. You can actually, all that information is available on internet search. Now, in the interest of time, I'm not going to go into that. So going back again to the foundations. So foundations means these are the most important things you need to address first. And then you can, of course, address the other areas. So every lifestyle change that you're looking at, if you are, let us say you look at sleep, you look at food, sleep, high quality sleep, sufficient duration of sleep will impact all these three areas. Food will impact all these three areas. Movement, if there is just one thing you want to do for your brain, I would suggest that is just move. Stop sitting so much. A few years ago, I made a decision, every Zoom meeting, I'm going to stand. I don't even have a chair in my home office. So I've just gotten rid of the chair, so I don't even feel tempted to do that. So this is, I'm going to keep the slide on for a little while. So this is from Dr. David Unwin, who's a family GP in the UK. This infographic comes from Diabetes UK site, actually. So here you can see, so what he did, there are some calculations. So he shares these infographics with his patients, and he has got dramatic results in his patients with diabetes using a lower carbohydrate approach. So you can see basmati rice is like 10 spoonfuls of sugar. Now, many of you love bananas because you see, you're supposed to eat lots of fruit, you know. Look at your banana. This is like almost 6 spoonfuls of sugar. Now, will you ever put 6 spoonfuls of sugar in anything knowingly? Then whole wheat bread. Sometimes bread can give you a much higher blood glucose response than any sugary stuff. Then, you know, potatoes, another very popular, you know, I love potatoes too. You know, so potatoes, you can see that. So this is one that, and you can find this, just do an internet search, you will find Dr. Unwin spoonful of sugar graphics, you will find all of these. Now, many people think, you know, cereals are, you know, very good breakfast in the morning, apple juice, brown toast. Look at this, 16.3 teaspoonfuls of sugar. And then you wonder why so many people are getting, you know, diabetes and worsening cognition and high risk for Alzheimer's all over. So I am going to end there. This is my website has a lot of free stuff. Just go to drkarmd.com/free. You can download this as well from one of the numerous free downloads. This is what I call lifestyle for healthy heart and brain. And I am going to stop there. And if you have any questions, please feel free to go ahead.
Shabnam, I have a comment, if you allow me.
Go ahead, for sure.
Yeah, you talked about this Finnish trial, this finger trial. Actually, Finland has a long history of this kind of trials, which started, in fact,
the North Karelia.
North Karelia trial started in 1969, probably the first trial which demonstrated that cardiovascular diseases can be reduced by about 80%. In those days, it's a long time. So people are used to this mindset is already there. So it's fairly easy to do this kind of trials in Finland rather than in India or something. And where in Finland, they also experiment very much with different foods. There is how the salmon could be cooked, or how spinach could be put in patties, and all kinds of things. It's not that like in India, you just have this biryani or basmati rice and chicken curry, or very nice. I get a bit what I should say, dreamy about thinking about all these things. I also wanted to come back to your slide on this continuous blood glucose monitoring.
Okay, do you want me to share that slide again?
It'll be nice if you could do that. And
okay, I will.
And it just yeah, that is so. You stop at 6 p.m. from 12 a.m. to 6 p.m. right?
No, I didn't stop here. His sensor ran out. His sensor was not working after that.
Okay. So I was just wondering that he must have something to eat after that also. So
oh yeah,
yeah. What? As you know, probably that I'm one of the nice guys who has got every possible thing, including diabetes from 2009. So it's 13 years on, and I'm right now trying to reduce my medications. And I just got a conformance with my primary care doctor. But anyway, the idea here in Finland was that the postprandial measurement should not be more than 8. It's in the same unit, which as you are here, and the lower, it's not really very much. And they still use this lower cutoff, something like 6. It's not 3.9. So it's but the postprandial glucose level should not go beyond 8. This kind of.
So, do you want me to comment on that? I have some pretty
Please.
strong views.
Please. I have mentioned this to what I should say, to probe your comments. That is.
Thank you. How are we doing for time? Because I don't want people to keep waiting. And
Anyway,
number one, I talked about higher than normal blood glucose levels in younger people. So 3.9 is the equivalent of 70. So 3.9 is below that, we consider that to be hypoglycemia.
Yeah.
And but so Shyam, there are many different aspects to your question. Number one is you are someone who has diabetes. So the most important thing is what is going to keep you safe, because in my world, I look at food first, and medications are definitely there. But sometimes when people go on to a lower carbohydrate diet, we have to reduce their medications before they even start the diet. So for us, getting to a target range of 7.3, we don't go up to 8. That is the ideal circumstance. That is usually changing food and when you eat, what you eat, how many times you eat, in what order you eat. That component of it comes first. Then will come, okay, if none of this is working, you're not able to make all those changes, can we make any other changes in your food or your time, or is it your sleep that is getting in your way? So for a person who has diabetes, can we safely bring the upper limit to a lower number, so let us say a 7.3, without adding another 20 medications, and more importantly, without pushing him into hypoglycemia? That is the most important underlying principle. Versus a person who does not have diabetes, he or she is not on insulin, not on any of the potentially hypoglycemic medications that can cause hypoglycemia. For them, I am much more strict. For them, after a meal, blood glucose should not ideally go up more than 30 to 40 points. Because what happens when your blood glucose levels okay, someone had a question. Okay, I'll come to that. Why? Jaydev, we will ask you to unmute yourself and you can ask the question rather than typing on this, because I can't read. So going back to someone who does not have diabetes but has metabolic syndrome, pre-diabetes, younger person, I am way more stricter. So in such a person, we have to do a much more deeper dive into personalized blood glucose response using a CGM. So Jaydev, do you have a question? Do you want to unmute yourself and ask the question?
Yes, I have a question. I am a little bit younger from you, but I have a question. The question is, the labor person from, I originated from a village. The labor and the normal person, the laborer worked hard and everything they do without maintaining any routine, but they are fit. At the end of the day, they are fit and stable, but we take care our health and everything, our dieting charts, but our health is we concern more about health, but we get sick earlier. That's the question, is how
So
it is.
what is your question? Your question is, how come a labor does not have as much illnesses?
Yes.
It would depend, because diseases like diabetes, and Anita practices in India, she can tell us, diabetes, hypertension incidence is going up dramatically in India's rural areas as well. So there are a lot of things at play here. Now the question is, Jaydev, if a laborer is able to maintain his health by doing a lot of physical labor, and you are someone who works in a corporate job, or your work is more, you need to sit, can you suddenly
Yes.
switch your life and start increasing your physical activity?
Yeah.
So it's not a simple answer. Yes, Dr. Raha, go ahead.
Yeah, can I just mention one thing that Shyam said about Finland and the studies going back for 4 or 5 decades in Finland. Most of the Scandinavian countries, including Finland, as I know, that they keep a comprehensive health record of the whole population. I'm talking about from baby to 100-year-old. It's a comprehensive record of the whole population, which doesn't exist actually in any other country, to my knowledge, in the world. And in UK, we've got NHS record, but that's only opportunistic when people go for vaccination or visit their GP or taking medication or go to hospital or see a healthcare professionals. Otherwise, there is no record of that person if person is healthy and well. So that makes a huge difference because you got a actually ready-made database of doing research. If tomorrow you want to pick up 50,000 people with a blood glucose between 5 and 7 millimoles postprandial, you can do that in Scandinavian countries or in Finland, but it will be almost impossible to do that without going through the way most of the research is done. So that's one comment. The other thing I want to mention about blood glucose, very limited knowledge.
Dr. Raha's screen is frozen.
But there are a lot of studies.
Dr. Raha, I'm sorry to interrupt. We couldn't hear the last few seconds.
All right. Somehow my saying internet connection is unstable. I don't know why. Can you hear me now?
Yes.
Yeah.
There are some studies showing that the blood glucose level probably less than 4, I will say, or I don't know, 4.5 millimoles in older people can affect their cognition.
Yes.
And they may behave cognitively mildly impaired just because of lower blood glucose. And that's why the treatment for diabetes in very old people and elderly, we quite often say it's better that you avoid hypoglycemia by keeping your blood sugars up a little bit rather than being optimal and ideal. So that's just a comment.
Yes, Dr. Raha, that is what I mentioned about, this is a personalized recommendation. It's not a blanket recommendation for everyone. What applies to an older person, the same thing will not apply to a younger person. You are absolutely right. Because our number one goal is to keep them safe, free of hypoglycemia. One more thing, Shyam, which I wanted to mention when I showed the continuous blood glucose monitor data is if someone's blood glucose levels go up very high, and then let's say they've gone for a walk and it comes down, this zigzag of up and down increases something called oxidative stress. Oxidative stress is again something very bad, which is related to cognitive decline, heart disease, everything. And this is information we don't know normally unless the person is willing to keep on doing, finger sticks. I haven't met anyone who does 10 to 12 finger sticks a day. So that is where the continuous blood glucose monitor for many of my patients, the CGM has been life-changing. They never realized how much their blood glucose would go up after a milk tea, no sugar. They are thinking, I'm not eating sugar. How can my blood glucose levels go up so much? Milk can raise blood glucose levels very high. So do we have any more questions? Otherwise, I think we can wrap up.
I have one comment. It's Sandeep Da has raised a very, very pertinent question about the medical records. In fact, Helsinki University Central Hospital has got second biggest medical record repository in the whole world. Wow. out of a population of 5.3 million people nowadays. Before, when I came here, it was 4.9 million. Now it's 5.3, and they have the second biggest medical records repository. And Karolinska Institute has got the biggest medical repository in the world, which is about from the population of 9 million people. And what I see from, as I said, that I'm a chronic, I'm a doctor's delight. I've been meeting doctors practically every week in my last 32 years in Finland. And I have seen from 1999 onwards, when practically every doctor, 100% of the doctors, 100% of the healthcare professionals, they use a computer. Right away on their desk, they have a computer. They can see all your images, all your prescriptions, all your blood test reports right away, and it is shared. I can see practically all of my blood glucose and X-ray reports and everything right on my. It is. And second thing, my idea of starting Trinnect was to bring this facility of having medical records at your fingertips for India for the first time. I think it was for the first time. And then, of course, I felt that there is a need for providing specialized healthcare expertise or consultation, or whatever you say, or second opinion. And of course, I'm trying to build up the team, which all of you are the esteemed part of it. I'm happy to be called. Somebody called me once that I'm the driver. I'm happy to be driver for all of you. Thank you.
We have to finish in a couple of minutes.
To ask Dr. Raha. What is the? Can you tell me? Is there any assessment tool that we use to determine PIM? Do you use it on a routine basis?
You mean for the medication, polypharmacy?
That's right.
Yeah, there is stop-start tool, which actually, I can share you the web link, and I can, let me just check. No, I haven't, I think I went through that slide very quickly. And
right. The thing is that in my setup, we are using several assessment tools. So I was wondering if your setup also is probably using any tool for this particular aspect.
No,
I mean, apart from the stop-start.
Stop-start tool is only for medication, only for pharmaceutical agent. That's all. And it has been validated, widely validated. First came out in 2008, and then it was reviewed in 2015. And there were actually, it was 13 countries, European countries.
Yeah, that's right.
Experts
India
from 13
does not
countries.
have its own PIM list, if I'm correct.
But it's a pharmaceutical agent in it, so its trade name doesn't really mean anything, because you're talking about pharmaceutical agent, and there are 80 items in stop and 34 items in start. So those are the 80 and 34 is in the paper. There is a table you need to look at for any patient. That's all. I can send you the link. I can send you the paper.
Yeah, sure. Thank you.
I think we have to call it a day now, because the recording is still going on. Thank you, everybody. And thank you, Shabnam. And I think you can have your breakfast now without milk.
I don't eat breakfast.
All right. Okay.
Thank you.
All right. I think India in India, it's a dinner time, isn't it? Okay, Sham, I'm going to end the meeting. Okay. And I will send you all the link. And you can forward it to anybody who wants to watch the video.
Thank you, everybody. Thank you, Dr. Raha, Sham,
Great.
Anita, for hosting.
Thank
Bye
you.
now.
Okay. Thank you, Anita. Okay. Bye, Sham. Bye-bye. Bye, everybody.